So I just also wanted to take this opportunity to thank our fantastic advisory committee who helped us to put together this 2 days program, and it included both clinicians and researchers and committee members. So it is, on our website. I have been so thank you so much to all of you who've been, putting up with us on Friday nights to be discussing the session. So that was very much appreciated, and it made the program so much richer. And it also certainly stimulated a very diverse approach towards our short presentations and hot topic presentations you will see over the next 2 days. In our tradition now, we would like to start this particular session also with hearing from our community members from another video that has been recorded from Dr. King and Evie.
I'm Evelyn, and I'm a JDRF advocate for South Australia. I go to Pembroke School and have type 1 diabetes since I was 6, so 9 years now. Clinical research will enable me to live a normal life, stress-free from having to juggle my diabetes management and everything else that I want to do. Intercepting and delaying the onset will mean that millions of other kids don't have to live like me. I can't remember a time where I didn't have to use pumps and sensors, or I didn't have hypos, or I didn't have to miss out on sport and could eat whatever I wanted to, like other kids. Through clinical research, I look forward to a time where I can't remember any of that.
I'm David King, Evie's father. I've watched my little girl manage this disease with strength and grace since she was 6 years old. Her diabetes is well controlled, but not without significant resources and effort from her and from the whole family. It's a daily, constant process that affects all aspects of her life. I'm also a vascular surgeon, and for years I've treated the end result of this disease, performed countless amputations, over 1,000 AV fistulae for dialysis, seen blind young patients with early onset heart disease. That will not be my daughter's fate. For now, we'll keep up our full-time efforts, but I look to the people in this room to solve this problem and cure this disease. Your work is vital. So please, save my daughter and prevent millions of others from ever having to live with type 1 diabetes and suffer its terrible complications.
So really powerful and moving words to keep us aware what the impact type 1 diabetes has on the families. Now, it is my pleasure to introduce Associate Professor Stuart Mannering from the St. Vincent Institute of Medical Research, and where he is a lead on, or the lead on the human immunology lab, and most of his research is to really understand how and why human T cells start and cause type 1 diabetes, and particularly in looking at the antigen-specific approaches. So he will be chairing the next session, and I will leave the session in his capable hands. Thank you.
Thank you very much, Devoto. It's a great privilege to be here, and I'd just like to thank Devoto and Mike and the team at JDRF here for all the work they've gone and they've put in to make this event happen. It's a great pleasure to be in a room with lots of friends and colleagues and enjoy the wonderful program, so thank you. So it's my privilege today to introduce the first of our keynote speakers, and that's Professor Colin Dayan. Professor Dayan is a Professor of Clinical Diabetes and Metabolism at Cardiff University School of Medicine. He has a long-established interest in translational research in the immunology of type 1 diabetes and is the lead for diabetes in the Cardiff Whole Pancreas Transplant Program. Professor Dayan currently leads the Clinical Engagement and Training Core of the Diabetes UK-funded T1D UK Immunotherapy Consortium and is chair of the Type 1 Diabetes National Prevention and Therapies Clinical Studies Group. And could I just say, as a resident of Melbourne, Victoria, it's a decreasingly rare privilege to welcome a champion from another Commonwealth country. So thank you very much, Colin.
Thank you very much, Stuart. And you didn't mention the cricket either, which is very tactful of you. Okay, well, actually, who's been praying for rain here? Okay, so thank you very much. It's a real pleasure to be here, and I've just really enjoyed this morning's discussion. I think laying all the facts out on the table together and having a big argument about it and discussion is a really powerful thing to do, and it doesn't happen that often. So I'm hoping to move the discussion on just a little bit now into, here's my title. It's over there. Moving towards insulin-free T1D, what is stopping us? So I have some, if this works. Should that work? Which one is it's the big green button, right? Should move it on. Okay, thank you very much. Okay, I'll just say next slide. Is that what I should do? So here are my disclosures. And then the next slide. I can just move on. Okay, so here's what I'm, just a summary here. So we published a little while ago a kind of an overview similar to things that you've heard before here, looking at the beta cell mass as it increases. And then, thank you very much. Okay. I don't know what this does have a laser pointer to it. Yeah. So B cell mass as it gradually increases then through intrauterine life, and then what we've heard a lot about today, the sort of pre-seroconversion stage, then stage 1, 2, and 3. Just before we get deeply into that, I want to just illustrate a few things that we've already done, really, or made big, not me, but other people have made great success at. So you can talk maybe about stage 4, which Dr. King in the video was really talking about, complicated diabetes, because it doesn't mean that just because you've got diabetes, you're going to get complications. And I'm afraid there is a stage 5 as well, which is premature death. And we've done pretty well in those areas, I would say. You know, to me, it's these guys that actually stopped premature death, because that was the routine outcome. Just remember that, 100 years ago, that's what happened. You died within 4 years, and they made that not happen. So that was done, if you like, or to some degree. But then thinking about complication-free T1D, so we have, if you like, death-free T1D, complication-free T1D. A lot of this is happening, the better glycemic control. I'm sure Evelyn, that we heard about, has got very much lower risk of complications than was the case 40 or 50 years ago. But things like statins, CV management, laser therapy, anti-VEGF therapy, renal transplantation, and now SGLT2 inhibitors, why can't we use those in type 1 diabetes? And maybe pancreas transplantation. All of these things are trying to disconnect the glucose from the complications. And there's a huge advantages there. So I'm using that as an illustration to say, what about the next step here? So we talked this morning about preventing stage 1, disease-free T1D. Let me call that disease-free T1D. That leads me into this, which is preventing stage 3, which I'm going to call insulin-free T1D. And that's, I don't have as many paradigms as Marion had, but that's my one paradigm here, which is to convert you into another way of thinking about this condition, that you can still have type 1 diabetes, you can still have the autoimmune process, but you don't need insulin. That's insulin-free T1D. So this is what I mean here. The disease has not progressed to a stage where insulin is required, but the disease process is still present, and the disease is managed differently now. It's managed with immunotherapy or other means, but not insulin, sufficient to maintain normal glycemic controls. Okay, so then you don't have a risk of complications as well. Okay, is this a good idea? What are the advantages of insulin-free T1D? Of course, you're all going to say yes, but I think it's important to spell them out, because people say, that's not a cure, Colin, you haven't got the cure, but how far have you got? Well, remember, if you don't take insulin, you have no hypoglycemic risk. That's it, right? It's insulin, it's the side effect of insulin, not of the diabetes. No need for lifestyle limitation. I remember the first patient that I saw at a pancreas transplant, and I said to him, what's so good about a pancreas transplant? Is it like you don't have the shots, so you don't have to do this, or the finger pricks? He said, no. He said, I can eat what I like. That was what he felt was the big issue. So, in terms of exercise and diet and so on, taking that away. There's no need for daily monitoring. Maybe there's some monitoring because you want to know how the disease is progressing, but you don't know every day, every hour, every half an hour what your glucose is if you've got enough insulin to manage. And there is no risk of metabolic complications because you've got ideal glycemic control. And of course, behind all of that is an improved quality of life. So I may be stating some things that are obvious here, but it's important to get a grip on them because otherwise people are saying, that's not really a good enough goal on its own. So what might insulin-free T1D look like? And this is an illustration here, if you like, of the area that you're in. So you might think that there's several interventions that would happen, and then you move from one to another, to another, to another. That's exactly how rheumatoid arthritis, multiple sclerosis, inflammatory bowel disease is managed, is that they move from one intervention to the next, as long as possible, keeping away from long-term complications. So that's what it would look like, and then it may go on for years. Okay, well, can we do this? Well, as Bob the Builder says, yes, we can. And that's one of the things I want to emphasize today. Yes, we can. So, of course, we knew we could do it with cyclosporin. This is a slide from over 20 years ago, but it was not acceptable. And that's why this date here, 26th of May 2021, people often think about the 17th of November 2022, but this date was a very important day. Because this was the time of the FDA advisory panel. And I'm just going to blow it up a little bit, the top left-hand corner here. The question was raised with this expert panel after a whole day of deliberation. Does the information that the applicant, in this case, Provention Bio, and the FDA, who'd reanalyzed all the data, show that the benefits of Teplizumab outweigh the risks in support of approval to delay clinical type 1 diabetes? In other words, for the first time, we were saying, is immunointervention in the pre-diabetic stage worth it? Does the balance work? And you can see in the little box there, it was pretty close, 13 to 10. This wasn't the final decision by the FDA, but this was a collection of experts, including David Nathan, who knows, and he voted no in this particular situation. But it was the moment when people began to think that immunotherapy was better than insulin. A very important moment. And then we need to build from there. So, and that resulted in the approval of Tzield, as you know, which has been emphasized, is an absolutely critical turning point in this whole area. So I want to look at it this way. So here's attempts at powered flight in 1900. This was never going to work, right? You just can't get enough lift from this. But then we did have this, which I'm going to call the equivalent of cyclosporin. I'm going to get into a bit of trouble here, but I like aviation, so let's go with this for a moment. So this is the Wright brothers in Kitty Hawk, North Carolina in December 1903. And they got this machine here to fly for about 120 feet, and it moved at 6.8 miles per hour. So you can run faster than that. So you could say this is just useless. But the point was that the point was made. Powered flight was now possible when it was never possible in 1900. And it was possible because of the two things. You had the wings that gave you lift, and the engine, it only gives you lift if you move quickly. And you have to move quicker enough to get enough lift. So then all you need to do is make a better wing design so you can lift it better, and a better engine to move it faster. So is this Teplizumab from 1927? In other words, the first non-stop transatlantic flight. So this was just 24 years later. This is definitely advantageous. You cannot run faster than this plane, and this plane managed to cross the Atlantic much quicker than any boat or anyone else could do at that point in time. That's a very significant advance. Not the end of the story, but you can see how once you've proved it in principle, you just do it better and better and better and better. And that's really what I'm going to focus on today. And an important part of that was this long-term safety of the therapy. That if it carried, like cyclosporin, a long-term risk, then in the end, it wasn't going to become acceptable. So generally, the long-term safety of anti-CD3 is very good. And the reason people get very muddled about this, I'm sure not in this room, is to realize, oops, sorry, can I go back? Okay, maybe I don't, it'll come up just in a moment. Let me just go to this slide over here. I want to pause a little bit, and through this talk, I want to keep coming back to, as you've done in this symposium, back to people and disease, because you have to match the therapy to the problem. So this is some research that we published about a year or so ago. And what it looked at, you might not think this is relevant, but it is. Just bear with me for just a moment. Up the y-axis is school performance. So this was, in the UK, people sit things called GCSE. In the old days, it was O-levels. These are external exams that everybody has to take. So it was looking at the performance in children with type 1 diabetes. And what it showed here was that the performance, the results, were exactly the same in this case, 1,200. It was all the children in Wales that had type 2(1)D versus all their colleagues, 263,000 of them. There was absolutely no difference in their school results at age 16 than the background population, which is a very important finding and amazing considering they had more time off school and they had other stresses. But, and there's a big but, it depends what your HbA1c is. So if you look here, look across the quintiles, what you can see in the bottom right is that the children where the mean HbA1c over their period of time was the worst, the highest, if you like, had a much worse exam outcome. But importantly, the people who had the best, which is the top left here, they had a better outcome than the background population. Now, get your head around this a little bit. Is this diabetes affecting your results? No, I don't think it's that at all. And the best evidence of that was this, that if you look at the duration of diabetes, it made no difference at all. It didn't matter whether you were diagnosed with diabetes under the age of 5 or diagnosed when you were 15, just before your exams, the results were the same. So this, to me, reflects the fact that there are many factors that influence people's ability to cope with disease. And generally, if you're not very good at learning or you've got stresses in your environment and there's a difficult family environment and those kind of factors, it's difficult to look after your own disease. So why is that important? Because there are certain people where insulin-free T1D will make a huge advantage for them because they will not be able to deal with the disease, whereas other people will be able to deal with the disease with what we have at the moment. And there are other groups that I think was emphasized this morning, and this is another paper that I contribute a little bit to here. More epidemiology, but this is looking at the National Diabetes Audit in the UK. So this is every young person, but cross-sectional data in the UK, and it's trying to show you HbA1c up the top left. The blue line, of course, is our target HbA1c of 53, and these are all aged, you can see, from 5 to 30. And there's also DKA admission rates on the right-hand side. So what is this trying to show you? Something that you all already know, especially the pediatricians here, which is that the HbA1c gradually rises from around the age of 10. So it's not when they transit to the adult service, I'm saying that as an adult endocrinologist, it's not the only time that it happens, but it does begin to rise and it peaks around the age of 17 or 18, and then it gradually comes down. Notice that the DKA admission rates go alongside this, and that the rates are higher in girls than it is in boys. So this period from 15 to 25 is a very difficult period, which you all know. So if the disease was not diagnosed until the age of 25, we wouldn't have this problem. And that's another reason for having the period of insulin-free T1D as long as you possibly can, so that you don't start your disease until you're ready to engage with it. And I like this slide here, which is now cross-sectional data from the National Pediatric Diabetes Audit in the UK. So what it's showing you is the mean HbA1c at the years during which you've had diabetes. And you can see that everybody starts in a good place. Well, we know this because it's like a honeymoon. It's quite easy at the beginning. So in the first year, everyone managed to, mean HbA1cs are around 57 there. But by the time you get out to 2, 3, 4, and 5 years, when you've lost your endogenous beta cell function, then things begin to rise, and they're highest in the teenagers. This is not because they have the worst diabetes or the worst disease, it's their engagement with the disease. And the youngest there actually do pretty well over that period of time. So everybody starts in a good place. If we can keep them in that good place, that's great. But the people who are going to benefit most are the people who are more socially deprived and people particularly around in the teenage years. They would be much best. Everyone can do it at the beginning. I just wanted to share you with some of my own patients. I'm going to mention a couple of cases through the discussion. And this was a young lady that I looked after for, well, until she died. And she always had an HbA1c in those terms of around 20%. And that was because she didn't feel she was worth treating. I saw her over 100 times. Her mother died when she was 14, and her mother died of psittacosis from actually the family parrot, family cockatoo, and she blamed herself for it. She said, I shouldn't be here. You know, this was wrong. I should have taken my mother to the doctors. That strong driver was too powerful for anything that I could do to overcome it, any technology, because she was trying very hard to feel that she was punishing herself during this period of time. And it only changed when she got married, which unfortunately was only 2 or 3 years before she eventually died and had many complications. So there are some very strong drivers to dealing with insulin. And if we can take insulin out of the picture, it would never have happened for Gemma. So I'm just emphasizing that these particular groups, teenagers, disadvantaged families, and mental health problems, and in that, the 2 groups in there are anorexia nervosa and drug abuse, which are terrible combinations with T1D. Okay, so I'm setting up the position of saying people for which this is really worth it. I want to introduce one more thing, with learning from your patients. And this is a rather strange situation, but it's happening to me. So this is a 21-year-old that actually I was called about by colleagues who was newly diagnosed with T1D in 2019, and he refused any insulin injections. He wasn't going to have any insulin at all. He still refuses all insulin injections. So I was contacted by the local colleagues and said, can you do anything about this? Can you give him insulin-free T1D, which is what they were asking me to do. But it was a bit late at that stage. We attempted compassionate ATG. I actually talked to Mike Haller about doing this, and he freaked out about having the injections, the infusion for the ATG. So it didn't even happen that way. But he was not a stupid lad. He did go crazy on the ward, and there was a cord of protection involved, and in the end, he was treated with Afrezza, the inhaled insulin, which he's still receiving at this point in time. But he was a science student, and he did extensive internet searching and paper searching and identified harmine as a potential beta-cell trophic agent. I must say, I didn't know much about this at this point in time. And he said, could I have some harmine, please? I thought, oh, for God's sake. Okay. And he said, well, hang on a minute. You can get harmine because it's part of the psychoactive substance ayahuasca, and I'm just wondering whether I can get hold of that. And he started to go on and on about this with me and saying, this is what I want to have. But actually, the more I looked into it, there is, of course, a basis for this, and actually, harmine derivatives are being investigated in order to, to regenerate beta cells. And there is, in fact, a clinical trial of harmine in this particular context. So what he's trying to do is come at insulin-free 1D from the other direction. If we could do something that would regenerate even slightly the beta cells, then that brings everybody else into insulin-free T1D because they're going to regenerate the beta cells, and then they're going to die again. So we have to then keep our insulin-free management going. So I'm just pointing that out, that although most of the people I'm going to be talking about are probably coming from the beginning of the diagnosis, if we could push back the other way, that would put a lot more people into having this insulin-free T1D management or immunotherapeutic management. Okay. And it's interesting, and this is, probably saw this paper published just recently, looking at residual C-peptide. And you can see, obviously, as you might expect, that there is a lot of C-peptide left for many years, particularly in 10 to 15-year-olds. So if you could get a few of those to regenerate and just push them back just a little bit, there's a lot of people out there who have got beta cells that could potentially move backwards, and then allow them, then I would have to maintain them in an insulin-free state. So here's the target populations for insulin-free T1D. Those identified through stage 1 to 2 through population screening, which we've heard a lot about this morning. Identified in stage 3A, either through population screening or opportunistically. And 3A, I'm going to touch on in a moment, is when you technically have diabetes, but you don't really need insulin at this moment in time. And then through autologous or beta cell regeneration in the way that we just talked about, whether that's taking harmine or however you're actually going to do it to get to that point in time. So just a little moment about stage 3A T1D. I just want to sort of flag this up just a little bit. Not everybody likes the term 3A, but there's definitely a moment, especially if you've come through screening, and I know Mariam was saying he wants to introduce insulin early, but there's definitely a moment in which you are not at ketoacidotic risk and you've got very good glycemic control. The minute you introduce insulin, you introduce the risk of hypoglycemia. So here was a hypothetical case. 28-year-old who was diagnosed through an insurance medical, and we are seeing more of this happening when he actually had an HbA1c of 6.8%, so he technically has diabetes, but they tested and he was positive for anti-GAD. probably like many in this room, we have patients like this, and they say, well, what can I do? I don't want to take insulin. What can I do? And you know, a lot of them are doing increased exercise and controlling their weight and managing things in that kind of direction. So this is a group that we're going to see more and more of, and most people don't know what to do at this stage or when to introduce insulin. And when we discussed it in this article, in the top left, you can see that exercise is potentially an intervention that might be appropriate at this stage. So I quite like the idea of diet or exercise-controlled T1D, because we're really stirring it up with the type 2 people as well. Right, that's all by way of, if you like, preamble to spending the rest of the time. I'm going to talk about the actual immunotherapeutic interventions, but I want you to get the context of it to understand where these interventions might fit in. So we do have a lot of interventions now which have some evidence, and we're going to hear more later this morning, about this afternoon, beta cell preservation, at least in the new onset space, and generally what works in the new onset we might expect would work in the pre-diabetes space as well. So I've categorized them here probably inaccurately into those with to do with effector cell depletion, regulatory cell expansion, antigen presentation, if you believe that's what the B cells are doing, cytokine inhibition, and beta cell protection. And I'm just going to flag up a little bit about each one of these things because they've got very different characteristics, and you would use them in different ways if you want to bring them together. So you're all aware now, of course, of Teplizumab, and that was a turning point of the original article, and then obviously the delay. I don't need to say much more about that. But this was the point I wanted to make earlier on, that it's a one-off shot, and you get a drop in T cells, and by 28 days, they're pretty much back to normal. This is why it does not carry a long-term immunosuppressive risk of cancer and infections and so on that people worry about. This is not immunosuppression, this is immunomodulation. And it's important to get your head around that although it does this for 28 days, the effects are going to last for a long time after that. But they probably don't last forever. And this is the long-term follow-up of the ABATE study looking at the C-peptide levels, suggesting that when they followed them up at a mean here of about 7 years afterwards, the difference in C-peptide, even in those who had responded well, was really coming back to baseline. So we kind of knew this and suspected it. This is great because it's one course and it lasts much longer than the T-cell effect, doesn't have immunosuppression, but it doesn't last forever, so we're going to have to think about what's next, even though 3 years is still a very good thing. A little bit about abatacept, and you'll have seen this was published. Fantastic study. Always makes me cry when I look at this, because if only they'd gone on for longer, we probably would be much more confident about abatacept at this point in time. It also reflects the fact that this takes such a long time because we don't know how to measure the outcomes in early stage. This was stage 1. This is not stage 2, this is stage 1 T1D with an intervention of abatacept, which was given for 12 months in the first instance. And you can see on the left-hand side, there was a strong suggestion it's delaying the progression to stage 2. It was harder to show the progression to stage 3, but needed a bigger trial, longer therapy. But there's a glitch in abatacept, which is, it's great at reducing central memory T cells, but it also hits your Tregs. So it needs fixing. And there are ways to fix abatacept that we're sort of looking into. So we can make that one better. And what about anti-TNF, where we were quite impressed with the results of the Golimumab trial. But if you look at this very carefully, something seems to be happening at 6 months. They were still treating at 6 months, and yet there's a fall-off in the C-peptide. None of these trials are going to work forever and in the best way. But to me, that almost looks like an escape, like you see in antimicrobial therapy, that eventually the disease begins to escape down a different pathway and may need a combination of something else to deal with that. And then verapamil, we heard a little bit about that this morning, and it was highlighted about whether it's acting through a direct effect on the beta cells or through the immune system. But what's interesting about this is, so this is the first study that was done from Anath Shalev, and you can see there was a rise in C-peptide initially, and then at the end of 1 year, it was about where it started from compared to the placebo. In 2 years, in her very small follow-on study, and it didn't follow everybody on, you can see that even at the 2-year time point, they were actually better than where they started. And that's why I think everyone was very surprised at the results of the second study, the CLEVER study, which was mentioned this morning, that they appeared to have a very similar C-peptide at 1 year than they had at the beginning. Unfortunately, this wasn't continued out to 2 years, so we don't know how long this would go on for, but it's intriguing that this might go on for quite a long period of time. So we're actually working on this, the Vera T1D study. This is a third study in adults, and it's a one-year intervention because the CLEVER study hadn't been introduced at that point in time. We are thinking about an open-label extension to understand how long this is going to last for. But this is now, currently we've got 91 randomized in this study. We're hoping that by the end of the year we'll have completed that, and that will be a third large study. After that, it's difficult to know where people will go next. Should be enough information maybe for people to begin to use this. I want to just highlight one more of the interventions here, because we did it, but also I want to make a particular point about it. So this is Uskatinemab. So this is a drug called Stelara that's been around since 2009 for the treatment of psoriasis. And psoriasis has well over nearly 8 drugs licensed when we don't have any, just want to point that out. And it works on IL-12 and IL-23, so has effects on these subset generation, Th1 and Th17. Now, our findings, which are as yet are unpublished, was that it had a delayed effect, and that when you got out to here, which was 12 months, there was about a 48.9% higher C-peptide. This is not good enough because it needs to start earlier on, but it did suggest that this pathway is important. And what was valuable to us was to look at the mechanistic studies we did alongside this. And with Tim Tree's lab, who did some fantastic work here, what we were able to show is that the drug reduced Th17, but particularly Th17.1 cells. So these are cells secreting IL-17 and interferon gamma, whereas we didn't have a significant impact on the interferon gamma cells alone. Hold on, I've got a justification for explaining this to you in just a moment. And actually, when we drilled into it even further, when Tim's lab drilled it into even further, for the first time, we could see an effect on antigen-specific cells. So these are antigen-specific cells responding to proinsulin and secreting IL-17, and they were reduced by the drug. And more importantly, when we looked at cells that express both IL-17 and GM-CSF and IL-2 and interferon gamma, this is a population that's tiny. It's less than probably 0.1% of the T cells out there. But when this was hit, you could see on the right-hand side, it gave you a 5-fold higher chance of maintaining your C-peptide in the last 6 months. So there was a correlation from hitting this tiny population to getting benefit. And the reason I'm emphasizing this is getting that more and more focused. Anti-CD3 hits a lot of cells, and ATG hits a lot of cells. But there are some small populations in there which we can take out with huge benefit, and most importantly with this. 0 adverse events. So this was the adverse event picture, and we knew this actually from Uskatinemab. It was extremely well tolerated. And this is very important from where we were at the beginning. You need a very well tolerated, very focused intervention that creates benefit. It may not do everything, but as we begin to put the pieces together, we're going to get a lot way further forward in our powered flight. So what is needed to accelerate progress in this area? We've got lots of tools in our box, but we need to put them together effectively if we want to have insulin-free T1D. We certainly need a rapidly sensitive outcome marker in stage 1. I'm not going to spend a long time discussing that, but it's a huge problem in trying to do early stage disease. We need a measure of disease activity that allows us to do this precision immunology. We need to know whether we've hit it right, because at the moment it's really hard to get the right dose of drugs, the right regime. We're fiddling around waiting for beta cells to change when we really need to know whether we've hit the disease. I'm going to talk now a bit about trial designs and more efficient trial designs, and what a global platform is a really important part, and of course we need more money. I just want to say a little bit about the outcome marker here, and this is looking at C-peptide, and this is Carmela Evans-Molina's data. What it's trying to show you is that paradoxically, as you progress through stage 1 to stage 2, the C-peptide apparently goes up. So the fasting C-peptide goes up, and the AUC C-peptide goes up until the last 6 months when it collapses. And this is because the glucose is going up, at least that's what I believe happens. So it's being driven. So this is not really what's going on. The beta cells are failing, but I'm trying to emphasize that C-peptide alone is a difficult endpoint, especially in prediabetes. Okay, I'm just going to skip that for the interest of time. Just going to move on to here. So I want to just say a little bit about trial designs to test combinations. So JDRF a long time ago were very interested in how we deal with combinations, and triggered by Simi Ahmed and colleagues, we actually put this paper together, led by Randy Anderson, thinking of ways to look at combinations. What I've been trying to tell you is we not need insulin for as long as possible. Each of the interventions has some advantages and disadvantages. Maybe if you put them together, you'll end up with something that's even more effective. That's how it worked in HIV. So this is now what we hope to be starting very soon, called T1D+. This is a platform trial. So a platform trial means that you have a standard protocol, and all the interventions just line up along the same platform. And if I can do it here. So the advantage of that is that you have a single set of controls. So it becomes much more efficient, because as you compare, what we hope to do is to compare, in this case, verapamil alone to verapamil plus golimumab, verapamil plus teplizumab, verapamil plus ATG. And we can share the controls between all of those. It also allows you to do an adaptive component where if one of these arms isn't working too well, we can stop recruiting to that arm and start recruiting to the other arms. All of this means that you need less individuals. So this is how the statistics works for this kind of trial, suggesting the number of participants that you save, and we're going to be aiming here to get in a position where we have 3 arms, but we had 4 arms going. We're saving 64 participants. And participants is time and it's money. So the more you do this, the quicker you can get the answers. And then you can do something even more clever, really, if you have the right outcome markers. This is what's called a SMART trial, or sequential multiple assignment randomization trial, which is reusing people. And it's a bit like what you would do in clinical practice. If this drug isn't working, you switch people to something else. But the way we've done it at the moment, when you have one intervention, that's the last time you can be in there. So the idea is this, particularly in prediabetes, that what you can do is that if people are progressing, then you would randomize them into a drug intervention. That's what I was going to show you on the first part over there. And then if they respond well to that, they stay in that arm. And if they're then progressing, you re-randomize them into another version, which might be a combination of 2 interventions. You can only do this if you have a way of monitoring the disease rapidly, so you know that they're progressing, for example, over a period of 6 months. So my overall roadmap here is to say that we've got non-antigen specific therapies, we've got sequential therapies, we have antigen-specific immunotherapy, which I haven't said anything about today because we don't really have those as yet, but they would come later. And then that would come into primary prevention, and then we've got, I don't know, whichever we want in terms of primary prevention. So what I'm trying to illustrate in this roadmap is we've got a good position now in non-antigen-specific interventions. We just need to use them as effectively as possibly can to maintain that period of insulin-free T1D for as long as possible. So here are my conclusions, that changing the disease towards insulin-free free T1D is now a tractable problem. Absolutely, we can do this. We just need to do it better and better. We have powered flight. We just need to fly for longer and better. Moving to insulin-free T1D has many benefits, especially in certain populations who are particularly at high risk of managing insulin. So it's definitely a worthwhile goal, even if you don't consider it a cure. And to accelerate progress, we need this kind of thing, linked screening and intervention programs, so we actually get people out of the screening programs, efficient trial platforms that we've talked about, rapid outcome markers, and smart combinations of interventions. So the idea would be, if insulin was discovered in 1921, that we try and eradicate childhood diabetes by 2041 by pushing the disease out further and further and further. And I do believe that that's a tractable problem. So just to conclude, I just want to thank everybody who's been involved here. And I think that wasn't quite the slide that I wanted, but because it doesn't include the funders in there. So JDRF and Diabetes UK have put an awful lot of money behind the work that we've done, as well as some of the UK funders here and my colleagues from the different institutions. I want to just, as the very last slide, just to return to people with type 1 diabetes. And this cartoon here was done while we were developing some information about prevention trials. And it shows a cellist who's playing the cello with an insulin pen. And I don't know if you know who this cellist is, but this is Sheku Kano-Mason, who's just a fantastic cellist. And his whole family took part in the abatacept study, and Sheku himself has type 1 diabetes. So I just wanted to show you a short clip of Shaker himself playing the cello, because this is what we preserve, is that incredible expertise that he has, and also several other of his family members who are also amazing musicians. So I'm just going to pass over to, can we just slip to that little clip? There you go. That's what it's all about. Thank you.
Thank you very much, Colin. That was fantastic, from aviation to classical music. So it's my honour now to introduce our next keynote speaker, Professor Tom Kay. Professor Tom Kay is Director of St Vincent's Institute of Medical Research. He's also an Honorary Professorial Fellow at the University of Melbourne. As many of you know, Tom's work focuses on islet transplantation and immune therapy, with their aim to challenge insulin replacement therapy for diabetes by introducing new treatments based on disease mechanisms. He is head of the Tom Mandel Islet Transplantation Program and Chief Investigator of the BANDIT clinical trial and the JDRF Australian Type 1 Diabetes Immunotherapy Collaborative, also known as ATIC. Tom.
Thanks, Stu, for that nice introduction, and thank you to Colin for that fantastic talk. I'm going to cover some of the same ground as Colin with a slightly different perspective in a much less entertaining way. So buckle in for a more boring ride. But that was great. And I really want to acknowledge Colin's incredible generosity to us locally we meet with Colin on a regular basis by video conference, and really he's provided terrific input into the work we're doing. So I'm going to tell you a little bit about the BANDIT clinical trial, as Stuart mentioned. The paper based on the BANDIT trial is still under review, and for that reason we'd be grateful if, and therefore under embargo, and we'd be grateful if people didn't tweet the results or publicise them too widely. We hope to be able to tell people more broadly about the results pretty soon. Okay, so so the outline for the talk is really, and this was made before Mark got sick, but talk a little bit about the background of type 1 diabetes very, very briefly, especially because not everyone in the room is completely au fait with the immunology of type 1 diabetes. I'm going to talk about the results of the trial. For those people who've not seen them presented, we've presented them twice previously, once at ADA and once at the Immunology of Diabetes Association, and talk a little bit about what we see as the path forwards from this point in time. Now, I want to acknowledge at the start the incredible team that did the BANDIT study. I think our experience is very positive. We had fantastic recruitment of participants into the study, and that was very much due to the team, particularly Michaela Weibel, our project manager, who hopefully is up there somewhere in the middle there, and also the trial sites, the Royal Melbourne St Vincent's in Melbourne, the Women's and Children's in Adelaide, and the Royal Children's. And I want to very much acknowledge my collaborator, Helen Thomas, who's going to be talking in the next little session, and she'll give a lot of the more biological background to the BANDIT trial, but none of this could have taken place without Helen's fantastic work. The trial was funded by the JDRF to the tune of $3.7 million US dollars, but although denominated in US dollars, the Australian JDRF also participated in funding the study. We're very grateful to them, and the drug was given to the trial by Eli Lilly. So this is an old slide of ours that comes from a pancreas obtained from a 16-year-old, well actually by the time this was done I think he was about 20-year-old subject who died while he was a university student at the University of Adelaide, And Toby Coates very generously identified that his pancreas would be of interest to study and he became an organ donor and arranged for us to receive his pancreas. And it shows for really the essential pathology of type 1 diabetes that hopefully people are familiar with, that it shows the loss of insulin staining in the islets, stained here in brown by immunoperoxidase, with the top left an almost normal looking islet, and the bottom right an islet with no insulin, no residual insulin at all, and all stages in between in this young man who'd had diabetes for about 3 years. And it emphasises all sorts of things about the natural history of diabetes. I guess I'm using it here to emphasise that what happens eventually in type 1 diabetes is that there are no insulin-producing cells in the vast majority of the islets eventually, even though at diagnosis there still are, and that's what the talk is about preserving the beta cells that are present at diagnosis. We went on to do lots of things with this pancreas, and particularly want to mention Stuart, our chair's work in isolating T cells from these islets and being able to identify that many of them recognise the C-peptide portion of proinsulin. Stuart was the first person in the world to isolate T cells from the islets and characterise their antigen specificity. Sometimes our colleagues in the United States, who none of the particular individuals are with us here today, but identify an investigator in the US as being the first person to do this. But I need to tell you that Stuart was the first person in the world to do this. So a little bit more data from this from Pete Campbell, who was a PhD student at the time in the lab, shows that about in this pancreas at 3 years after diagnosis, about 40% of the islets still had insulin containing cells. And of course, down in the histology here, you see an islet with no insulin staining, and that islet stains with glucagon. So in the field, these are called pseudoatrophic islets. That was a name, I think, given to them by Gepps when he originally described this pathology in this sort of kind of pathology in the 70s. And I guess, again, what I'm emphasising here is you can't bring back what's not there. So it's not possible at this time in the evolution of the field to reconstitute the insulin-secreting cells in an islet like this. An interesting part about the biology of the disease is that the immune cells that infiltrate the islets, they're only interested in islets that have residual insulin in them. So the T cells are attracted into islets which still have the antigen that they're specific for. We told you that a lot of the cells recognise proinsulin, and so the cells are there are busy attacking the islets that have proinsulin, no longer attack the islets that do not have proinsulin in them. Oh, now what is that about? I think this is a case, this is a funny, I don't know how this has come out like this, but it's supposed to be a photograph of a case report where a bone marrow transplant was done from an individual with type 1 diabetes to their sibling without type 1 diabetes, and the disease occurred in the person who received the bone marrow transplant. And I think what I'm trying to emphasise here is that this disease is all about the immune cells. Even though beta cells, of course, involved, this is primarily an immune system based disease. And this is actually a picture of a recurrence of autoimmunity in a whole pancreas transplant, where you put a normal pancreas into someone who's got type 1 diabetes. And in some people who receive a pancreas transplant, you get recurrence of disease. Despite immunosuppression, you get recurrence of disease. And you can see that in the top panel that the islet autoantibodies go up at the time that there is recurrence of disease. I guess emphasising to me that under these circumstances, the disease is somewhat independent of the insulin-producing cells. It's really a disease that's driven, at least at this stage of the evolution of the disease, entirely by immune cells. And why am I saying this? In some ways, I'm saying this as a bit of a response to Colin's comment about exercise and diet being a possible therapy for type 1 diabetes. I think we need to while I think it's an interesting idea, I think we really need to accept that what we're dealing here is tackling the immune system rather than tackling metabolism. And that's a little bit of a thought process thing that we as endocrinologists need to accept. This is in the autoimmune disease game, not in the metabolism game like we would be in treating type 2 diabetes. For example, to me, type 1 diabetes has much more in common with autoimmune diseases in other disciplines than it does with type 2 diabetes. This is a rather spiritual metaphor for the course of type 1 diabetes that was created by Michelle So in our group. And of course, you know about the evolution of type 1 diabetes from previous things you've seen today. And in particular, you're seeing here the wax candle has burnt down at the time that diabetes is clinically diagnosed. And there are some interesting parts of this metaphor, the idea that you can't reconstitute with any ease that wax candle at this time. I think most of us would accept that endogenous beta cell function, the natural way to produce insulin, has advantages over exogenously delivered insulin, even though that's improved very much. And we have this time-limited opportunity to save what's left at the time of diagnosis. What we're trying to do by treating with disease-modifying therapies at diagnosis is we're trying to arrest further irreversible loss of beta cells. We're in a very similar position to people treating rheumatoid arthritis. What we're trying to prevent is irreversible damage to the end organ, and that's what we need to focus on in what I'm talking about today. Okay, so to continue that theme, most of us are aware that Banting, in his Nobel address, commented on the fact that insulin was not a cure for diabetes, and also that the JDRF, our host today, and thank you very much to them, have as part of their mission to find a cure for diabetes, and you heard that eloquently described by the people, by the King family at the start of this presentation. So we are responding here by addressing these issues. We are responding to the best evidence we have about what the community of people with diabetes is looking for through the messages delivered to us by the JDRF. Okay, so I want to talk about immunotherapy because that's what the talk is about, and I'm going to cover a little bit of the same ground that Colin did about the evolution of immunotherapy. Immunotherapy means different things to different people. These days it's more about immuno-oncology actually, the idea of stimulating the immune system to tackle metastatic cancer in various diseases. But in our field, it's more about trying to dampen down the effect of the immune system. Stimulation of the immune system can be general, and that in immuno-oncology can result in autoimmunity, the general stimulation of the immune system. But when it's antigen specific, and for example, an immunisation against COVID, its side effects are rare. And the same progression is there with immunosuppression for transplantation and so on is associated with well-known side effects, but as it becomes more specific and more targeted, it becomes safer. And in many ways, this is a slide from the cyclosporin trials that Colin showed, and what this slide shows that for about almost 40 years, we've had relatively effective immunotherapy for type 1 diabetes. The thing that's been missing has been safety, efficacy with safety, and really the focus on the studies we do today has to be as much on are the drugs safe as are they effective, because in reality there are effective drugs already out there, and this shows the drop in insulin, administered insulin in people starting cyclosporin in one of the French studies done during the 1980s. So what I've been trying to emphasise are that diabetes is a disease of the immune system primarily. Baricitinib is an interesting drug because it tackles the immune system but also has effects on beta cells. Once the immune attack has occurred, those beta cells are not really coming back, or what you're left with is a whole lot of glucagon positive cells. At clinical diagnosis, and several people have emphasised this, there's been substantial irreversible beta cell loss, much greater than that present at the first detection of stage 3 diabetes when people are followed into stage 3 diabetes. So quite a lot of insulin production is lost in those months after diagnosis. After diagnosis could be made before clinical diagnosis is generally made. So far, as far as we know, we can't spontaneously regenerate beta cells, although Colin's patient had some interesting ideas about that, and safety is very important. So now we're going to talk about the BANDIT study, and that's a trial of baricitinib, which is a JAK inhibitor. The first time that JAK inhibitors, this class of drugs that have been around for about 10 years, have been trialled for type 1 diabetes anywhere in the world. There have been a couple of previous case reports, but no clinical trials. And this shows the design of the study, that we assessed 106 participants. They were randomised, 91 were randomised, recruited in about 15 months. They were randomised 60 to baricitinib and 31 to placebo, so 2 to 1 baricitinib to placebo. They were randomised within 100 days of the onset of type 1 diabetes. We had very few withdrawals, and the primary endpoint of the study was the C-peptide measured after a mixed meal tolerance test. Now, I think on the next slide is the primary outcome data, the C-peptide, at 48 weeks after mixed meal tolerance test. Oh no, these are the baseline characteristics. Sorry, the baseline characteristics roughly the same in both groups. There are a few more males than females in the study. They are a mixture of children, young and adolescents and adults from 10 years to 30 years of age. You'll see that their T1D duration got quite close to the 3 months within 3 months of diagnosis, and they had this level of C-peptide after a mixed meal tolerance test was consistent with other studies in the field. Now, in the primary outcome data, the C-peptide after the mixed meal tolerance test in the baricitinib group is shown in blue and the placebo group in black. And at 48 weeks, there was about a 50%, 48 to 50% difference between the placebo and baricitinib group, and that was highly statistically significant. And over the course of the study, from baseline to 48 weeks, there was no significant change in the C-peptide level in the baricitinib-treated subject, so that they were basically stable throughout the course of the 48 weeks. There are slight increases and so on, but none of these blue spots are significantly different from each other. They're different from the placebo group at all the time points measured, starting at 12 weeks of age. And as Colin's emphasised in other talks, in many of these trials, successful trials, you can see differences between the active and placebo group quite early in the trial. So here from 3 months onwards. Now, and I should say this was done on an intention to treat basis. So this is all comers. Now, consistent with the retained C-peptide levels, the insulin dose, the administered insulin dose shown here on the left was decreased in the baricitinib subjects compared with the placebo, and that was true both for the basal and the bolus amounts of insulin. There was no difference in the hemoglobin A1C across the study, and this is quite common in these trials because part of the treatment in the trial is that there's a treat to target protocol in the trial sites, and that makes it difficult to spread the groups in terms of hemoglobin A1C. But there was CGM done in the studies, and despite the lack of difference in hemoglobin A1C, both the CGM time and range and the variability were improved in the baricitinib subjects. You can see the time and range is greater in the baricitinib subjects. This is in the left panels, and and the time above range reduced in the baricitinib subjects. And this was also quite striking in measures of glycemic variability, such as coefficient of variation and standard deviation, as shown on the right top. And we had very little hypoglycemia in the study, and so there was no significant difference in hypoglycemia. Now, I mentioned that adverse events, side effects are an important part of these studies. We did not see any difference in adverse events between placebo and baricitinib participants. And in fact, there were more, there was a tendency for there to be more adverse events in the placebo-treated subjects. There are some serious adverse events involving admission to hospital, and these again were slightly more in the placebo-treated subjects. None of them directly related to the study drug, a couple related to compliance with insulin treatment, and a couple of completely incidental things such as the playground accident resulting in liver laceration. Now, the study was done during the COVID pandemic, and there was no difference in COVID infections between the placebo and baricitinib group. There were more, of course, in the baricitinib group because there are twice as many subjects in the baricitinib group. There was a modest number of people with acne in the study in the baricitinib group. Of course, this was done in adolescents, so there were also people in the placebo group with acne, and it turned out that roughly the same number of people in both groups wound up being treated actively with doxycycline for their acne, so a modest increase in acne. So what we found in this study is that a single daily tablet of 4 milligrams once a day can stop disease progression in type 1 diabetes measured by C-peptide. And this was associated with reduced CGM, blood glucose variability on CGM, improved time in range, and lowered insulin requirements. And the drug was well tolerated with few side effects, especially in this age group. In some other autoimmune diseases, in old people with rheumatoid arthritis, there have been some side effects of concern, but not in this treatment age group. Bearing in mind this, of course, a modest-sized study compared with the very large studies that have been done in other diseases. So we would hope that in the end, these sorts of outcomes would result in fewer short and long-term complications of diabetes, and that, in principle, baricitinib could potentially also be useful in stage 1 and stage 2 diabetes. This is not, of course, a cure for diabetes. We know from the pharmacokinetics and other aspects of the drug and that its use in other diseases that when you stop taking the drug, the treatment effect wanes. And because of the low number of residual insulin at diagnosis, most of the participants in the study, not all but most, were still taking some insulin for the duration of the study. But in my view, these points shouldn't prevent us seriously considering the potential of the drug for clinical use. So there's a list of potential next trials and ideas, and actually it's very similar to the list that Colin showed about the same kinds of things we're interested in starting earlier, start therapy as soon as possible after diagnosis, not waiting for 100 days, trying to get as early as we can in the disease course, understanding how persistent the benefit is into second and subsequent years of treatment, and combinations of therapy, testing other JAK inhibitors. There are multiple on the market, and so on. So the next step for us is to really understand the interest of the drug company, Eli Lilly, in pursuing registration of baricitinib and what would be required for that. And I feel that the JDRF, maybe the point's been made before in this meeting, that researchers like us know almost nothing about the second half of the innovation cycle, that we know almost nothing about issues to do with regulatory affairs, reimbursement and so on. And it's great in this way to have the support of the JDRF who've done a huge amount of work on understanding what the FDA is looking for with these therapies. And I think in this slide it is some discussion about that is based on the 2022 clinical review of Teplizumab that the FDA has concluded that C-peptide can be considered a reasonably likely surrogate endpoint, meaning that its connection with for example, reduced complications and so on, is indirect via its ability, the ability of endogenous insulin to improve control. So the FDA is interested in C-peptide, but it's not right up there yet as a surrogate marker. And these studies, it's difficult to get these disease-modifying treatment trial outcomes to the level that will convince the FDA, because of the difficulty in demonstrating effects on hemoglobin A1C, which people are interested in, primarily because of this issue of treating to target, and the lack of impact on severe hypoglycemia, because at this stage of diabetes, with significant endogenous insulin, even in the placebo group, the events are very rare. So we're very interested in what will happen when Lilly consider taking the trial to the FDA and what they will require further. We've also got other issues on our plate. We believe lots needs to be done to disseminate information about disease-modifying therapies in diabetes to our endocrine colleagues. I think Sanjoy made the point yesterday that it's one thing to convince people at major immunology centres about the benefits of these treatments, but the high street endocrinologist, or however you want, the endocrinologist in practice needs a lot of education, reassurance, bringing up to speed, and so on about the potential use of these treatments. Most of us as endocrinologists have been trained that type 1 diabetes is treated with insulin replacement therapy. So we need to understand the barriers and talk to people about what can be done there to prepare the workforce. And we've heard a lot about the need for expanded screening, introduction of new biomarkers, and also the importance of data and data linkage. So what will happen next? Well, when we release the data, it'll be interesting to see what impact that has on the type 1 diabetes community, and think about what can be done at diagnosis to optimise disease-modifying therapy and insulin replacement to achieve hemoglobin A1C in the normal range, which I really believe can be done. I don't see these treatments at diagnosis as replacing insulin in any way. Despite Colin's talk, I see them in the first instance as working closely with insulin to produce extremely good outcomes, and then identify people who are most likely to benefit and thus reduce the physical and mental burden of disease. And this will require quite a lot of changes in type 1 diabetes care management, as we've heard from people throughout the conference. Is the future of diabetes, type 1 diabetes, seeing people who you're trying to prevent from progressing to fully fledged type 1 diabetes. So earlier treatment is what we're all after. Longer treatment gives them more likely to give greater improvements over placebo in the second and subsequent years. We'd be very interested to see how that pans out. This study shows that JAK inhibitors as a class have activity against the autoimmune process, but we really don't know exactly how to best use these drugs in the future. And one part of this is understanding the early time after diagnosis, the honeymoon period, understanding that better, and that I think deserves further investigation. Thanks very much. I hope I haven't gone on too long.
Thank you very much, Tom. I'd just like to remind people that Tom and the BANDIT team ran this trial during COVID, which in Melbourne we had a particularly world-leading severity of our lockdown, so it was an incredibly difficult time to do anything, and it's a real credit to the BANDIT team and the participants that the trial was completed and such an amazing outcome. So it's my pleasure now to introduce the final keynote speaker this afternoon, Dr. Eleanor Ramos. Dr. Alan Ramos is Chief Medical and Chief Operating Officer at Provention Bio Incorporated. Dr. Ramos holds an MD from Tufts University School of Medicine and completed her training in transplant nephrology at the Brigham Women's Hospital. She's a healthcare industry veteran with more than 25 years of experience in the biotechnology and pharmaceutical industries, including significant clinical expertise in autoimmunity, inflammation, organ transplant rejection, and the treatment of acute and chronic viral infections. Welcome.
Thank you very much. I'm really honored, and it's a pleasure for me and for my colleagues at Prevention and Sanofi to share the journey of Teplizumab as a disease-modifying therapy for type 1 diabetes. These are my disclosures. So, as many of you know, type 1 diabetes is an autoimmune disease, and it progresses through stages, and it occurs in individuals with genetic risk who develop 2 or more T1D-associated autoantibodies. And we know that people with genetic risk encounter a trigger. We think perhaps it's a viral trigger, and that this initiates the immune process that starts attacking the beta cells or the insulin-producing cells of the pancreas. Therefore, it makes sense that we would target this disease with an immune modulator such as Teplizumab. So Teplizumab is a monoclonal antibody directed against the CD3 molecule that is part of the T-cell receptor complex. The binding of Teplizumab to its receptor sends a partial agonistic signal with 3 key downstream effects. It inhibits the pathogenic autoreactive T cells. It converts those autoreactive T cells into exhausted T cells and increases regulatory T cell function. And so the end result of these 3 events is that, if you will, there is restoration of tolerance that in some individuals is that we have sustainability of that tolerance for some individuals that we've observed in the trials. So this is a very daunting slide because it may be very discouraging that the development history of Teplizumab has been ongoing for about 3 decades. It's important to note maybe 3 distinct eras. The first era between 1990s and 2010. And then there's this very long period of very little activity of almost 1 decade, from 2010 to 2019. And then the most current era, where we now have increased activity that finally led us to the approval of the first disease-modifying therapy in T1D, stage 2 T1D, in November of last year. The other thing to note here is that Teplizumab has been tested in both stage 2 and stage 3 T1D, but the bulk of the studies have been conducted in stage 3. All right, let's look at the early studies conducted in the 1990s and 2010. And those include the studies of Study 1 and ABATE and DELAY, which showed promising data on beta cell preservation measured by C-peptide. So this same data compelled Macrogenics to acquire Teplizumab in 2005, and in collaboration with Eli Lilly, they developed a registrational program, 2 pivotal studies, 2 phase 3 studies, the Protege and the Encore studies, to be able to get the drug approved for stage 3 T1D. Unfortunately, they missed the primary endpoint. The primary endpoint was a composite of hemoglobin A1C and insulin use. However, that study, like the earlier studies, confirmed the preservation of beta cell function as measured by C-peptide. So the results of the Protege study essentially stopped the development by macrogenics in type 1 diabetes, and Eli Lilly exited as well. And they put it on the shelf. However, the development did not stop because of the perseverance of the academic community, including Kevin Herold and his TrialNet investigators, and with the support of the NIDDK. And they, backwards here. I think must have skipped something here. I must have skipped this slide. This is the data from the Protege study, and just to highlight that they missed the primary endpoint, which is the composite of hemoglobin A1C and insulin use. There were 3 dose regimens of teplizumab that were tested, the full dose, the low dose, and the 6-day regimen, and they did not differ from placebo, which is in the gray bar here, in the composite endpoint, which is an unvalidated endpoint, never used in prior trials, unfortunately, and also they did not show any difference in the change from baseline in hemoglobin A1C, and this is really what stopped the development program. Indeed, Kevin Herold and his colleagues at TrialNet, with the funding with NIDDK, started this trial, the first trial of teplizumab in stage 2. It was a randomized, double-blind, placebo-controlled study in patients with stage 2 T1D, and the entry criteria are noted on the slide. Patients had to have a relative. It was a relative of a patient with T1D, age 8 years or older. They had stage 2 diabetes, defined as 2 or more T1D autoantibodies, and the evidence of dysglycemia. There was a 1-to-1 randomization, and the primary outcome was the time to the diagnosis of stage 3 T1D, and of course, we also measured safety. Now, I wanted to point this out because I think even in this era, it's very difficult to run these trials. Back then, the enrollment was challenging because you had to find stage 2 participants by screening the relatives with established T1D. And eventually what happened was that the sample size was basically cut in half, from 144 to 71 in 2014. The study started in 2010. And what that means is that you had to ask a lot more of the drug, meaning that you had to have a greater effect size to maintain the power. But despite the fact that they cut the sample size in half, it still took 8 years to conduct the study. Enrollment from 2010 to 2017. And then you had to wait for the last patient to develop type 1 diabetes. And in this trial, they had to wait for at least 40 patients to develop that endpoint. And so that happened in 2018. And of course, the results were disclosed a year later and published in the New England Journal of Medicine. And it showed that indeed teplizumab delayed the onset of clinical T1D. As you can see here, the median time to the onset of T1D was delayed from 25 months to 50 months, a difference of about 2 years. And this had a hazard ratio of 0.41, meaning there was a 59% reduction in the risk of developing type 1 diabetes, and this was highly significant at 0.066. Now, consistent with the data from the stage 3 studies, the C-peptide was also observed to be preserved in the TN10 study. And this is the profile of the C-peptide in these patients, the teplizumab patients in pink, the control in gray. And as you can see, prior to the initiation of study drug treatment, everybody was losing beta cell function. C-peptide was falling, and as soon as the treatment was started, the patients on teplizumab had stabilization, whereas the patients on placebo continued to lose their C-peptide. And these two curves are significantly different with respect to the AAC over 6 months or to the slope between the two treatment groups. Now, after the end of TN10, there were two mechanisms by which these patients were followed. One was via the TrialNet protocols. They did an extended follow-up, and a study called the TN10 extension study. And I need to mention that somewhere in this timeline, Prevention Bio acquired Teplizumab in May of 2018. And so we set up this study called TN10 extension in order to allow patients who were on the TN10 study, who were free of diabetes at the end of that study, to be able to receive Teplizumab if they developed clinical T1D. So Sims and colleagues in 2021 published the extended follow-up of TN10, and at that point, there was a sustained delay in the median time to the onset of T1D, now of about 27 months, and it was still significant at 0.01, and the hazard ratio still showed a 54% reduction in risk of developing type 1 diabetes. This is the TN10 extension study design that we developed at Prevention in order to be able to allow those patients in TN10 who developed T1D, and they were allowed to receive it within 12 months of their diagnosis. And this study completed enrollment and is currently in the follow-up phase. So what about prevention's role in the development of type 1 diabetes? Really, based on the promising results like macrogenics, collectively over the last couple of decades, and even before we knew the results of the TN10 study, we acquired the molecule in 2018, and specifically to run another pivotal phase 3 study in stage 3 T1D. And this is the study called the PROTECT study. The one thing that we did differently that was done by macrogenics is that we reviewed all of the data, and we chose the criteria for the study to be able to have the best benefit for the patients in this trial. And those include enrolling younger patients, because Protégé enrolled up to 35. We were going to enroll children and adolescents. And we had to really get them early in their disease, within 6 weeks of diagnosis. And the other thing that we had to do is they had to have beta cell function to protect, because in prior studies, the entry criteria was basically a measurable C-peptide. In our study, we want to make sure that they have a minimal amount of residual beta cell function in order to be able to protect those beta cells. So the design of the PROTECT study is shown on this slide, the objective being to determine whether Teplizumab slows the loss of beta cells and preserve beta cell function, now in children and adolescents 8 to 17 years of age. The primary endpoint is C-peptide, and we're measuring that at 78 weeks, or roughly 18 months. And the secondary endpoints, as you might imagine, we'd be looking at exogenous insulin use, the HbA1c, time in range, hypoglycemic episodes, and of course, safety. And in this study, we gave 2 courses of Teplizumab at time 0 and at 6 months. It was a 12-day regimen. The plan was to enroll 300 patients, randomized 2 to 1. Again, age 8 to 17, newly diagnosed within 6 weeks. They had to have a measurable residual beta cell function. Of course, they have to have the diagnosis of type 1 diabetes. By the way, that study has completed enrollment, completed follow-up, and the data is currently being evaluated. The other thing that we knew we had to do was to develop a mechanism for following the PROTECT patients for longer period of time. And so we developed the extension study to PROTECT, and to essentially have a follow-up of every patient in that study who wishes to enroll or is eligible to enroll up to 60 months or 5 years. And so this is currently enrolling and estimated to complete in a couple of years. So while we were running the PROTECT study, we were able to facilitate the approval of Teplizumab in stage 2 T1D with the US FDA. And this is really based on the results of the TN10 trial and supportive data from all the prior stage 3 T1D studies where we culled all of the C-peptide data in order to support TN10, because TN10 was a relatively small study. It was 76 patients. But our supportive data included many hundreds of patients with C-peptide results. And so the regimen is noted here. This is the approved regimen. And importantly, as part of the approval that we received from FDA, we had 2 important post-marketing requirements. The first is to follow patients in a registry. These are patients who receive commercial drug, and they have to be followed a minimum of 10 years. And this is going to be important safety data. And I know Colin mentioned a paper by Perdigoto, and this is Kevin Harold's ABATE study, where they looked at follow-up for up to 7 years and showed no safety issues in that long-term follow-up. But we intend to follow patients in this registry for 10 years. The other key post-marketing requirement, and it was something that we would do in any case, was to conduct a trial in patients less than 8 years of age. And this is a study that we call the PETITE study. It is a single-arm study, and patients are stage 2 patients who are less than 8 years of age. It's a small study, 20 participants, mainly to assess safety as well as PK and the immunogenicity of teplizumab. The study is currently enrolling, and we estimate the completion to be around 2026. Okay, I think now it's really important to go over the safety data of teplizumab. The safety database of teplizumab, in my opinion, is one of the largest for an immunomodulator therapy in type 1 diabetes. We have a database, and this is not even including the PROTECT study that will be looking to look at the data, but which enrolled 300 patients, of whom 200 or at least 200 are going to be teplizumab. But in our filing, the BLA filing for the stage 2 indication, we had almost 800 teplizumab-treated patients. We call that the ISS, the Integrated Summary of Safety Population, and includes the 44 patients that were treated in the TN10 study. Now, you might hear of this modified ISS, and this is because 18 patients in here are patients in the DELAY study who were initially in the randomized the placebo arm and received a course of teplizumab. So when we were talking with the FDA, they wanted a pure population. They did not want the original 18 patients that were randomized, and so we have this population, and when you look at some of our data, we'll be referring to this modified ISS population. So before I go through the warnings and precautions and the most common adverse events, I think it's important to say that the adverse events or adverse reactions seen with teplizumab occurs during the dosing period, the 14-day dosing period and the 28 days after the end of dosing. They're predictable, they're transient, and they're manageable. So with respect to warnings and precautions, we do see cytokine release syndrome, serious infections, lymphopenia, and hypersensitivity reactions. The most common adverse events occurring in greater than 10% were lymphopenia, rash, leukopenia, and headache. Now, cytokine release syndrome sounds very scary, but this is not like the cytokine release syndrome that you see with oncology drugs. This is likely the result of that partial agonistic signal that is sent by teplizumab, and it is the release of cytokines that cause these signs and symptoms. And it's seen in about 5% of our ISS population, and in the TN10 study specifically, about 2%. The cytokine release syndrome typically occurs within the first 5 days of dosing and lasts about 3 days. And the important thing is that the vast majority of patients who develop cytokine release syndrome can continue the 14 days of treatment despite the fact that they develop that during the treatment. The other thing to note is that liver enzyme elevations can be seen with CRS, And this typically occurs during the first week and usually resolves within 1 to 2 weeks. Like any immunomodulators, you have to be worried about infections. And this slide shows serious infections, meaning these are infections that led to hospitalizations. And we saw a 3.5% in Teplizumab patients, 2% in controls, and most of them were related to, if I can read it, cellulitis, pneumonia, abscess, sepsis, shown down here. Of course, with any immunomodulator treatment, it is not recommended to start this type of therapy with an active infection or a chronic infection, and that we need to monitor patients for infections during the course of treatment and after treatment. Lymphopenia is a very classic side effect, a common side effect of Teplizumab, seen in almost 80% of patients. This is because of margination and not depletion. And this is a very, very characteristic profile, I know Colin showed this, of the decline in the lymphocyte count that happens immediately after you start dosing, and it naders at day 5, and then it starts to improve even while you're giving the treatment. And it resolves fully by 42 days, or roughly 6 weeks. Hypersensitivity reactions have been seen with Teplizumab, as you can see here, angioedema, peripheral edema, at these rates, and urticaria, but the most common hypersensitivity reaction is rash. So these events must be monitored, particularly in the TN10 study. There was one patient who developed serum sickness, but this patient had an underlying history that may have increased the likelihood that the patient developed this particular side effect. Rash, I said, is relatively common. We see that in about 50% of patients. It's rarely serious. It typically happens within the first week and resolves within 7 days of the start of treatment. So again, the path was long, 3 decades, to get to the approval of the first treatment, disease-modifying treatment in type 1 diabetes. To be honest with you, I was involved on this part of the slide in the 2003 era, because I worked at the Immune Tolerance Network, and I worked on this drug with Teplizumab with Kevin Harold, and I had much less gray hair at that time. And then when I got a call in 2018, I was talking to Jeff Bluestone. Of course, he is important in the creation of the molecule, and he said, Leni, this drug is still sitting with macrogenics, and you need to find a way to get this to patients. So the message here is we have to be persistent. It's a long development timeline. It doesn't mean that the next one is going to be as long as this. And I would have to say that it also, not only is it the strength, the courage of the people like you, the JDRF, all the patient advocacy group, but also the sponsors now have to be courageous. Courageous that it's not just about the market potential. Courageous that it's because the patients need it. And that's why we have to keep going. So on behalf, again, of my prevention colleagues, my Sanofi colleagues, I'm so pleased that we're able to be able to get Teplizumab over the finish line. This is not the end. This is not the end of the life cycle development of Teplizumab. We have so much to do. So much to do for patients, so much to do for improving the durability, but then to open the door for other immune therapies in this space. Thank you.